Respiratory system is not only lungs. Respiratory system starts from the tip of the nose. That's the most visible part of the respiratory system.
Yes.
And then it goes as a main breathing pipe, and then multiple branches of the breathing pipe. They turn into sacs of air. Where the whole thing is respiratory system. To talk about the statistics, literally one person is dying every 5 minutes in our country with TB. That's way more than COVID. But TB is 100% treatable and curable. Asthma we have known for now thousands of years, to be very frank. Even in Ayurveda there is a lot of mention about asthma. Certain people are born with certain kind of tendency like allergy, and there could be allergy to some flora fauna also. Even if somebody is staying in a very natural place where there is a lot of greenery, those pollens also can trouble a person. So everybody's susceptibility can be different. Commonly people say that I have fallen sick or I am falling sick again and again, my immunity is low. But in this case, immunity is working in a wrong direction. Overactive. It is on overdrive.
Is asthma treatable or curable?
I would say 100% treatable. And apart from medical treatment, a doctor has to advise them about all these things that we discussed.
Hey guys, I'm Tarun. I'm co-founder of Orange Health Labs, and welcome to the Orange Club podcast. Here we are going to talk about all matters around health, and we're going to make it easy to understand and even easier to act upon. Hi, welcome to the Orange Club today. Today we have Dr. Samir Garde, who's one of Mumbai's most well-known pulmonologists with over 24 years of experience in respiratory medicine. He's trained in managing lung infections, complex endoscopic procedures, asthma, pollution-related lung issues, lung fibrosis, and also ICU ventilatory care. He's very passionate about public education. He has worked on spreading awareness about respiratory illness, tobacco hazards, and ways to protect ourselves from pollution and infections. I'm excited to have him with us on this podcast. Welcome to the podcast, Dr. Samir.
Hi, Dr. Samir. Thank you so much for taking the time to join us on the Orange Club. It's our pleasure to have you on board and to listen to you about your field and learn a lot about pulmonology.
My pleasure too. Thank you for having me on your show.
Thanks.
Thank you so much.
So, and Dr. Samir, just to demystify, and this is how usually we start your field to all our listeners. What is the field of pulmonology about, essentially? What is the main focus, and what is it that you treat in general?
So in the gross sense, pulmonology means field of respiratory medicine. So we are specialists in all respiratory disorder, diseases of the lungs, as you can say. But respiratory system is not only lungs. Respiratory system starts from the tip of the nose.
Yeah.
That's the most visible part of the respiratory system.
Yes.
And then it goes as a main breathing pipe, and then multiple branches of the breathing pipe. They turn into sacs of air. That the whole thing is respiratory system. Unfortunately, a COVID had to come for people to realize that there is such a specialty of medicine called as respiratory medicine. Whereas this has been in practice in our country since late 70s. So last 55 years. Pulmonology or respiratory medicine has been existing as a super specialty, to be very frank. Now, grossly, we can divide the conditions that we look after is respiratory infections and non-infectious conditions. So in the respiratory infections, we deal a lot with TB, and that can be a separate podcast altogether.
Yes. I think we are the TB capital of the world. We are among.
Unfortunately, we are. Yeah. Sub-Saharan Africa, and we are still. And there is a humongous task in front of us to eradicate TB in next 5 to 10 years. It's a difficult one, but not an impossible one. And non-tuberculous respiratory infections like various virus or bacterial infection. And in non-infectious diseases, we look after mainly asthma, smoking related lung disorders, which is known as chronic obstructive pulmonary disease, then interstitial lung disease, and that is popularly known as lung fibrosis. We also look after lung cancers, as in we may not be directly involved in chemotherapy of a patient of a lung cancer, but we are the ones who diagnose it, and then maybe we do certain interventional procedures in certain cases of lung cancer. We also look after obstructive sleep apnea, which is a type of sleep disorder. There are 84 different sleep disorders, and obstructive sleep apnea is one of them. And so we, as pulmonologists, look after that. My own area of interest is also in mechanical ventilation. So suppose if a patient is in ICU and on a mechanical ventilator, then how to manage, because lung mechanics is a very different ball game, and every intensivist or a chest physician, a pulmonologist, needs to know the intricacies of this. So it's an entire spectrum of illnesses that we look after.
Or you've given us like so many chapters to now go through in this field. And just for we can just for us to help us shape this conversation better, how would you in your practice define as what of these conditions do you see most often in youngsters today? Like, let's say people in their 20s and 30s.
Okay.
I'm sure there are a lot of respiratory cases even with young children actually.
Absolutely. So in metropolitan areas of Mumbai, Bangalore, Delhi, of course, wherever there is pollution in the ambient air, a 2-year or a 5-year-old child is also suffering. Typically, we look after people who are 18 years and above, but I do see a lot of younger crowd than that. But as you rightly pointed out, yes, we can kind of classify them in these age groups, that what kind of diseases we see more. Frankly, respiratory infections are common in all age groups. Their presentation may change, the complications may change, how a patient comes with clinical symptoms in a certain age may change. For example, somebody has TB in the lungs. A 20-year-old person or a 50-year-old person or an 80-year-old person, the presentation can be different, but it does affect entire spectrum of age group. Even other viral or bacterial infections can present at any age group. So that is like, you can say, uniformly all across the age group. But yes, in somebody who is in 20s, and commonly in city like Mumbai, we see what is called as allergic rhinitis and bronchial asthma. Asthma we have known for now thousands of years, to be very frank. Even in Ayurveda, there is a lot of mention about asthma. That is
even before pollution. No?
Even before pollution.
Okay.
Because certain people are born with certain kind of tendency like allergy, and there could be allergy to some flora fauna also. Even if somebody is staying in a very natural place where there is a lot of greenery, those pollens also can trouble a person. So everybody's susceptibility can be different. So,
just for my understanding, when you say these allergy, it's basically our own immune system which is
correct,
overacting against us. It's not particularly that particular matter is bad for us.
Agreed. So commonly people say that I have fallen sick or I am falling sick again and again, my immunity is low. But in this case, immunity is working in a wrong direction. Overactive. It is on a overdrive. So typically the eosinophils, as we know, I'm sure now our common people also know about eosinophilia. White blood cells, a type of white blood cells going up. It can happen because of worms in the intestine, or it can be a part and parcel of presentation of allergy. And particular blood test that is done for this is called a serum IgE level.
Correct.
That will define whether somebody is born with an allergic tendency or not.
Okay.
People who, so a typical history given by that kind of a patient will be, when I get up in the morning, I sneeze 20-50 times, then my nose gets blocked, then I get itchy eyes, then I get itchy throat, and once all that settles over the day, then after a couple of days or in a week's time, I may get phlegm in my chest, which takes time to get better. Now this phlegm in the chest description is actually the description of asthma. So what is happening is there are thousands of breathing tubes inside, and they go narrow. The diameter of those breathing pipes go narrow. So the air is not flowing fluently through those windpipes, the branches of windpipes. And that is when these symptoms come. There is inflammation inside the inside of the wall of the breathing tubes. There is a lot of mucus or phlegm production inside. These are all presentations of allergic rhinitis, that is allergic cold, or some people also get sinusitis, allergic sinusitis, and which finally leads to bronchial asthma.
So just for a layman, because I also have this confusion a lot in this thing, and I've seen a lot of young kids also, suffer with this, especially in Bangalore. I've heard that there's a lot of pollen in the air there, and it causes that. What is the difference between an allergy and asthma, or is it that asthma is a higher end level of an allergy, or like when do you say I have just allergies, it's fine? When do I say like, oh, I've gotten asthma? It's just not very clear.
Yeah. So I'll tell you, allergy is you can say a defect in your system that you are born with. One can have allergies on the skin, one can have allergies to certain food items, and one can have respiratory allergy. This is broadly this is how we classify. Allergy is a defect you are born with, and the respiratory presentation can be this allergic rhinitis or asthma or both together. Generally, we say that somebody who has asthma need not have allergic rhinitis, but somebody who has allergic rhinitis will one day for sure will present with symptoms of asthma. So when you say I have allergy, that means you are just born with an allergic tendency. There are people who have a abnormal IgE level. That is one gross way to measure it, whether somebody is born with allergic tendency. In scientific term, it is called as atopy. Atopy means out of place.
Okay.
Body is giving an exaggerated response to a polluting agent or indoor pollutants like mosquito repellents or incense sticks or candles that are burned. Everybody wouldn't suffer, but somebody who has this allergic tendency will have a lot of these symptoms. So when you say asthma, then you're talking about cough, wheezing, breathlessness, and these kind of seasonal presentations, etc. So when you say allergy, you are born with a tendency of allergy. And when you say asthma, you are actually talking about a disorder which needs investigation and treatment.
Okay. And when is it that the treatment is basically you need to get treatment for this? If you're thinking that you are getting breathless essentially, is this when you think that this is serious enough for me to do, or what are the general symptoms that you see early stages of developing asthma in patients?
Right. So as I said, a history of allergic rhinitis or sinusitis is very, very essential. Any good doctor or a clinician or a pulmonologist has to first ask that history. Because a 20-year-old boy will typically say that I used to get, when I was 10, 12 years old, I used to get sneezes as my this thing. That went away. For last 7, 8 years, I did not have anything, and now I am having this.
Okay.
Now, breathlessness is, yes, which is a very well-known symptom of asthma. We all know about it. But cough which is not going for more than 2 or 3 weeks can be a first presentation of asthma. We call it cough variant asthma. Asthma in the form of cough.
It's like a dry cough or
it's a dry cough, generally classically a dry cough. Somebody who has done some kind of exercise or done some kind of exertion, or some people get up with cough in the night, or they are just having cough unrelated to anything. Classically, it will start like I had some viral fever. I had couple of days of fever and little runny nose. That went away, and my cough is not going for last 3 weeks. So cough variant asthma is a very, very important variable as far as asthma is concerned. Then some people will come with wheezing. They will say I wheeze in the night. The rest of the day I'm fine, but I'm wheezing in the night. Or after doing some kind of exercise, I'm wheezing. That is called as exercise-induced asthma. And then yes, feeling breathlessness is the final presentation of asthma, which can happen with climate change, exposure to dust, exposure to any kind of pollution, or after a viral or a bacterial infection, where people literally come to the hospital ER, to either to get admitted or to take some kind of inhaled medication, some IV, so as to feel better.
So one of the very interesting things that you mentioned was, I get wheezing at night, and I've seen this with people who have suffered with these kind of symptoms. They tend to get worse at night. Yeah. Why is that?
So when you go to sleep, if there is, and that generally is the case, even if you wash your, bed sheet, pillow cover, etc., time to time, of course there is house dust everywhere. Also, depending on how the bed hygiene is around you. If there are books that you have kept nearby your bed, which have collected some dust, Or there are people who use this liquid or matte kind of mosquito repellents, which are literally at the head end or somewhere in the room. So once these people go to sleep, you have inhaled enough amount of dust or these kind of pollutants for a couple of hours. Say around 10:30, 11, you fall asleep. And by 1:30 or 2 a.m., you wake up with cough or wheezing or breathlessness. This is because they have inhaled enough amount of those indoor air pollutants in that particular time.
And if you're allergic, maybe dust mites also from the bed.
Dust mites, yeah. Because when you say dust, it is the dust mites. Okay. Now there are lots of pets everywhere in the house. Cat and dog, they shed a lot of hair, dander. And that particular dander has a typical mite again. Like you have a dust mite, there is a mite on that dander. And that exposure also can push you into these symptoms of wheezing. So essentially, again, the breathing tubes have gone narrow, the air is not flowing properly, and that's when your symptoms start.
A lot of these people I've seen, they're using air purifiers in their bedroom, right? And now they're also using humidifiers, right? Are these kind of things useful at all in these households where people are suffering from these things?
So first and foremost, I will recommend that declutter your bedroom, whichever way you can. Or if you have, so there are children and then there are parents staying, in same bedroom, there are soft toys kept. Whether those soft toys are washed or cleaned properly.
Or even laundry clothes and all.
Laundry clothes, the books as I mentioned. So first of all, try and declutter and try to dust out your surroundings in the bedroom. That is the first thing one can do. If you are not staying in a really polluted area, you do not need a humidifier or a air purifier. If you are using an air conditioner, that needs to be serviced properly. That is the basic thing one can do. And if yes, in places like Mumbai, you are literally staying by the roadside, the highways, there are so many old buildings which are close to the roads, which have now really become highways, and there's a lot of traffic on that. Then in such cases, yes, having a air purifier makes sense. In Mumbai, humidifier doesn't make sense. But in drier cities like say Bangalore or Jaipur or Delhi, if your ambient air is too dry, because then your nasal mucosa also gets dried, and then your inhalation through the nose is not good. That's when you can maybe have a humidifier. But all these equipments need good maintenance, servicing.
So they itself can
yeah, exactly
add to the
problems. Yeah.
Fair enough. Is asthma treatable or curable?
I would say 100% treatable. In a small percentage of people, curable also.
Okay.
And the way to diagnose it is like the protocol that I follow is somebody who comes with these symptoms, we ask for a chest x-ray. We ask for a sinus x-ray because there has been a history of allergic rhinitis, sinusitis. A serum Ig blood test, and of course a pulmonary function test. That's a computerized breathing test. Now, and of course, before all that, I have to examine the patient properly, clinically, take a good history, and then come to this diagnosis. And once that is done, and apart from medical treatment, a doctor has to advise them about all these things, about all these things that we discussed. Ambient air pollution within your house by burning incense stick, camphor, candle, mosquito repellents. Best is to avoid all this. Declutter, dust, animal dander, etc. We discussed.
So basically, remove all the things that can trigger the
that
attack.
can trigger all the triggers. Thick upholstery, thick carpets or thick curtains on your window.
Actually, no one thinks about carpets in the bedroom also there.
Because it holds dust, and finally it is the dust that will trigger the whole issue. Once that is taken care of, treating the allergic rhinitis with a proper intranasal medication and proper inhaled medications for asthma. Now, they are known as pumps. Inhalers. So, pump is just one way of drug delivery to the lung. There are capsules which can be broken in a device, can be inhaled. There are these pumps. These pumps also come with a spacer. Then there are nebulizers. But what matters is the right type of combination of inhaled bronchodilator and inhaled corticosteroid. Now, when we say steroid, people go on overdrive.
Yes.
Oh, you're on steroid.
The thing there like bodybuilder injection
Correct.
things that you're putting.
Correct.
Right.
So first of all, our body generates steroid every day because it's part.
We'll discuss both the points. We'll discuss what are bronchodilators and what are steroids. Both.
Sure, we will. So body. So it's one of the hormones like thyroid and insulin and other hormones. Body is producing steroid every day in the body. They are glucocorticoids, mineralocorticoids, etc. So glucocorticoids, and these the inhalers that have the potency of the inhaled glucocorticoids that these inhalers have, they are in microdoses. What they do is they take care of the inflammation. The inside of the airway is inflamed. There is a lot of phlegm that needs to be taken care of, and the bronchodilators will dilate the bronchi, as the name suggests.
Ease the breathing.
Ease the breathing. Whatever had gone tight, got strangulated, gets dilated, and both these together take care of all the pathology that is happening there. And that is how they ease out your breathing, not only symptomatic betterment that, oh, I'm feeling better now. No, they prevent these episodes happening again and again, because if these episodes of I feeling breathless, going to the doctor, taking some temporary medicine, feeling better can carry on for 10-15 years. By the time from 20 I am 40, 45, these airway defects become irreversible. Then nothing works.
This is a very important point I want to just stress upon. A lot of parents of young children, right, they take a self-decision on discontinuing medication thinking that my child is becoming medication dependent.
Correct.
Right? But like you're saying, if you have these symptoms and a pulmonologist or a doctor has recommended this to you, you don't do it, it can lead to
Absolutely.
long-term.
Long-term.
If you could just explain that a little bit, like why is it safe to continue taking the medicine, and is there any danger per se that these parents feel? What is the danger for taking these kind of medicines?
No, so there is no danger. As in, first of all, this is the most scientific way of treating this problem. So, couple of things that I try to explain them in a lay language. For example, if there is a skin issue, what will you do? You will put a ointment or a powder. If there is an eye issue, you will put the eye drops. There is a lung issue. The medicine has to go to the lung. This is the first, most basic scientific thing. Inhaled bronchodilator and inhaled corticosteroid combination have been there for last 30-35 years, and there have been umpteen number of studies which have shown that they are very safe even in growing children. It doesn't affect any bone growth. It does not affect any hormonal changes in the system.
It doesn't create any dependency.
It doesn't. Now coming to that, the dependency debate. We both are wearing spectacle.
Yes.
Okay. Why are we wearing it? Because there is a certain defect to the eye. To keep it rectified every day and to make our life easy, we are wearing this. Is this our addiction? Is this our dependency, or this is our need? This is our need. So the inhaled medication is a need of that child. I'm sure you must have come across, it's not so common, but still, a 9-year-old girl or 10-year-old boy diagnosed with type 1 diabetes, which was previously called as insulin dependent diabetes, or a 5-year-old boy diagnosed with hypothyroidism, means thyroid levels. What will you do?
Have to give medicine.
Lifelong. That person has to be on thyroid medication or insulin lifelong. So similarly, somebody who is born with an asthmatic tendency, this kind diagnosed properly scientifically, has to be on inhaled medication, very ideally lifelong. But as I said, there is a small percentage of people who can go off medication, provided lifestyle is taken care of. Once you are better, you start deep breathing exercises. Pranayam, Surya Namaskar and swimming is what I recommend strongly to everybody as focused breathing exercise. You can do any other activity. You can play football, badminton, cricket, Zumba, gym, whatever for fitness. But for focus, respiratory health, pranayam, Surya Namaskar are of immense help. And then there are certain people who are born with this allergic tendency. The allergic tendency behaves in cycles. Somebody who suffered from asthma-like symptoms at the age of 5 will suffer like that for 10 years. We treat them for that period with inhaled medication. suddenly the symptoms go away for next 10-15 years, unexplained. Then you do not give the medication. This person may come back again at the age of 30-35 with similar symptoms.
Okay.
Again, treat them with inhaled medication till the time you can treat it, till the symptoms go away for another 5-10 years. This is also seen.
There's nothing to panic about.
Nothing to panic about. Keep doing a pulmonary function test every year or every once in 2 years. And that is the best way to keep a check on your lung health as far as asthma is concerned.
Fair enough. This pulmonary function test, right? How does it determine whether you have a breathing problem or not? What is it exactly testing in you?
So basically, it is trying to pick up the pathology that we discussed. The multiple breathing tubes going narrow is picked up when you do certain breathing maneuvers. There are certain graphs and numbers that we see. And with that, we say, okay, there is a mild, moderate or severe kind of defect. And once that is seen, we ask them to take a bronchodilator inhaler. After 20 minutes, the same test is repeated to see whether what kind of improvement we are seeing.
This is improvement in lung capacity.
In the lung capacity, correct. Of course, this is a little kind of, you can say, difficult to do test. Not every patient understands the instruction to perform it properly, because you need to really hear it out from the technician who is instructing you to do it. Now there are certain other simpler tests that have come in, like force oscillometry technique, especially a 5 or 6 year old child or an 80-year-old man who is not able to do those breathing maneuvers in a pulmonary function test. So then this force oscillometry technique is a very simple, just do tidal breathing. That is the routine breathing in a machine. And it gives again graphs and numbers. The interpretation is slightly different than the pulmonary function test. But that also gives us information about the lung status.
Fair. I kind of, got, to me as a layman, right, felt a little contradictory, like saying that you said, asthma can also be exercise induced. And then at the same time, you said, I encourage you to do swimming and all, right? I encourage people to play and all, right? So what is it like? If something is going to cause, can an asthma patient have a relatively normal life with regards to playing, swimming, all of these things, or are they like not supposed to do it and they can't do it?
They have to do everything that a person who is not having asthma is doing. That's the whole idea of treating a patient of asthma, that they should be able to live a normal life. Go to Leh Ladakh, go for scuba diving, play any kind of sport, and they can do it. I can name at least half a dozen athletes right now, but I cannot, who are having asthma and they are fit and playing their game very well.
Wow. Okay.
So exercise-induced asthma means when somebody comes and tells us that I had cough which lasted a longer period, or I felt breathless after doing a particular, say, 100-meter sprint. Everybody will feel breathless, but something out of proportion. Then that is called as exercise-induced asthma. And again, it is treatable, maybe not on a long-term inhaled medication basis. Just take the inhaler before that activity.
Okay.
Or there are certain medication like Montelukast, which is a tablet, which can work in that way. And once they are able to exercise properly, they can overcome this.
Fantastic.
And that is how it's good that you pointed out the contradiction in this, but yes, that is how it works.
Does it help? Like these things like lung exercises or swimming, is it actually true that it helps improving your lung capabilities?
It does, as in whatever lung capacity, suppose it is it's a case of bad asthma, as in number of years of suffering and symptoms.
Just from my understanding, some people, a lot of things understand it like as if it's like a weak muscle and it needs to be exercised to make it stronger, but it's not that exactly.
It's not like that. It is like, as we discussed, any small trigger going in and suppose you are in a tunnel, a dark tunnel for 2 to 4 kilometers, and suddenly you step out in sun in your vehicle, how your eyes will
squint.
They will contract. So that kind of a reaction by your breathing tubes to a certain exposure, that is all that is happening, and you're taking care of that. So once you exercise, whatever your given lung capacity is, you have to maintain that. And your respiratory efficiency is not only the lungs. There are very vital respiratory muscles, the most important being diaphragm. There is a big muscle between the chest and the abdomen cavity, which is moving like a bellow, that is called as diaphragm. That's one of the most important respiratory muscle. And then there are multiple intercostal muscles, which are respiratory muscles. So keeping those respiratory muscles healthy is very important. Interestingly, keeping your limbs strong, whatever age, suppose we see a case of COPD, which is at the age of 70, 80, we make them do limb strengthening exercises. We ask the physiotherapist to do this for us.
Why?
Limb strengthening goes a long way in taking the load off your respiratory system. If your limbs are stronger, then suppose there is a patient of COPD, which is like you can say big brother of asthma, who's feeling breathless while taking bath. They say that when I've done taking water from a bucket, I'm exhausted. I'm too breathless to do this. So 2-3 days they may not have a bath unless there is a caregiver for them. Yeah. So once you strengthen your limbs, this activity becomes effortless for them. The load is taken off the cardiorespiratory system.
Ability to do anaerobic exercise essentially.
So physiotherapy goes a long way.
Wow.
And that is when, so it is not only the lungs or the breathing tubes in the lung, it is your respiratory muscles. It is, and any exercise, of course, gives you a mental high. You feel good. It's a feeling of well-being.
Yeah, absolutely.
So why let go that?
So coming from, like somewhat chronic and sounds like semi-chronic kind of a condition of asthma in youngsters, the other one that you were referring to was around having acute illnesses, right? Like getting infections for which they come to you and all. One of the recent memory you mentioned in your conversation to begin with, how pulmonology became center stage was through COVID. And the COVID kind of like, it seems to be again and again keeps on coming back in waves, right? We just recently saw actually at Orange Health Labs also, we saw another spike that happened just in this last month, right? So just for our understanding, what is the actual relation between it's a respiratory illness essentially, right? So what is the mode of is it like any other viral infection? Is it different from standard viral infection? And how has the treatment and our understanding of COVID evolved 3 years since it has come to being now? Are we less scared of it?
Essentially, it is you can say a million-year fight between any organism, be it bacteria, virus, fungus, TB, and human beings. Sometimes we overpower them, sometimes they overpower us. And that fight is going on since eternity, and it will continue till we all exist.
Okay.
Till the earth exists. So these bacteria or viruses, they always try to make themselves more lethal because we have found some medication, some vaccine to fight them. COVID itself is a type of a coronavirus, which is a known respiratory virus for so many years now.
That's existed before 2020.
So coronaviruses, there's a huge family of coronaviruses. COVID-19, a name was given to this particular virus, which was like a kind of, you can say, a genetic mutation that happened in the coronavirus, which became so lethal and caused a pandemic. Essentially, coronaviruses, adenovirus, rhinovirus, respiratory syncytial virus, influenza, parainfluenza A, B, and influenza means human, bird, swine, any, will cause similar respiratory symptoms.
Okay.
It will be runny nose, it will be body ache, it will be fatigue, it will
fever,
be cough, etc. So they all cause the same symptoms. COVID-19, that is that novel coronavirus, the novelty was that it caused blood clots. That was the novelty. That was that novel name given to it. A respiratory virus will, in say 0.01% cases, will cause serious illness. 0.01%. Be it influenza, whether it is human influenza, swine flu, bird flu, or other coronaviruses, will cause 0.01% people to go in ICU. This is a known thing. But since this particular virus also caused clots in the blood, not only of the lungs, where the lungs literally became stone-like, or also clots in the blood vessels going to the heart, blood vessels going to the brain, etc. And that's why the scare. And that was the novelty of that virus. Prevention is the best way by wearing once you are suffering, you should always wear a mask, preferably a N95. Suppose I am having cough, cold, fever. Ideally, I should not go out of my house for say 5 days. Generally, 5 to 7 days is a time when your body itself overcomes all this, or you may need some kind of symptomatic care. But coughing has to be always cover your cough, or if you have done this, then wash.
Yes.
And eating fresh fruit, having a lot of water, veggies, that will improve your immunity in that period so that you can fight it out. And doctor may prescribe you some kind of symptomatic treatment. Any such virus, now coming to your point, it keeps coming in again and again. If you know, there was an epidemic of H1N1 in 2015, if I'm not mistaken. It was an epidemic, it wasn't a pandemic. It happened in certain areas of our country. All these viruses become part and parcel of the respiratory virus flora. They become a part of that entire bouquet.
You mean inside our body?
In the surroundings.
In the surroundings.
In our climate.
In a city climate.
In our climate. And at certain point, some virus becomes, so it will be a season of H1N1, it will be a season of para-influenza A or B, it will be a season of rhinovirus or respiratory syncytial virus, it will be a season of COVID. Now, since it has made rounds in the population and since we are all vaccinated, it has lost its teeth and nails. So it will cause you all those symptoms, but not that severity.
Okay.
So they are here to stay. They will always, raise their head in some or the other way. Susceptible ones will suffer, but suffer as in these kind of symptoms and recover.
So on the recovery piece, right, there still seems to be this, there was this like new terminology that came on, which was called long COVID, right? Basically sustained symptoms for a longer period of time beyond the standard duration of a week or 10 days that you said, right? What is this long COVID essentially? And like, is this something that eventually goes away or it stays with you forever kind of a thing?
I'm not particularly very fond of this terminology. I do not myself agree with this concept. Yes, COVID did cause blood clots and cause maybe more fatigue than other respiratory virus would cause. But something that is happening at the end of 6 months or 1 year after you suffer from the actual COVID, whether to call it a long COVID, I am still not comfortable with it.
Okay.
As far as respiratory complications are concerned, the severe lung damage that it caused, either it took away the lives or those patients after a few months, they recovered completely. This is my observation. Maybe less than 1% would have sustained those lung injuries which have continued as that lung fibrosis which it caused, but not like a lung fibrosis that is caused by exposure to silica or other pollutants, or exposure to pigeons. That kind of lung fibrosis that comes in, that literally increases. That kind of lung fibrosis, at least I have not observed. Either they succumbed or they completely recovered. A very less minuscule percentage of people are having those scars in the lung, but they are literally minuscule, and they have not progressed in last 5 years.
Okay.
So it is not a progressive lung fibrosis.
Okay. Fair.
So I am not, I do not agree with that terminology of long COVID a lot, to be very frank.
Good to know then. So, okay. So then moving on to other infectious diseases, which you may still catch little early in your life. You're still in the age group of 20s, 30s, and there you hear cases of TB. Right? It's kind of scary because TB is still one of the leading causes of death in our country, if I'm not wrong.
Yes.
Right? And certain kind of TB, I'm told, are like non-treatable once they enter your system, right? So how does one get infected from TB? Can it happen to anyone, or is this something which is to do with the kind of surroundings you stay in? Like what increases my risk factors of catching TB, and how can I stay safe in general?
To talk about the statistics, literally one person is dying every 5 minutes in our country with TB. That's way more than COVID. And our focus has to be on getting rid of TB always. Whatever any epidemic or pandemic comes, okay, you treat that, but our focus cannot shift from this menace called TB. It can affect any part of the body except hair and nail. Okay, we all are harboring TB bacilli in our lungs, all of us.
Okay.
In Indian subcontinent.
Okay, that's an uncomfortable thought.
So we are infected, but we are not diseased. Try and understand this. Infected means that virus or bacteria is staying in my system. In our respiratory system, at any given point of time, we are having a lot of bacteria that we carry. They are called as commensal. They are not troubling us. They are part and parcel of our flora. Like you have good bacteria in the gut.
Correct.
So they are there. Similarly, we are all exposed to TB bacillus in our subcontinent, and we have all taken BCG vaccine. It's a very good thing to do, which will protect us against severe form of TB. It may not protect you from not getting TB, but from severe form of TB.
Okay.
So we all are harboring that. Once your immunity dips for whatever reason, then it will show up either in lung. 70% will suffer from lung TB. 30% will suffer from anywhere else except hair and nail, as I said. It can be a swelling in the neck, which is called as lymph node TB. It can be in the intestine, a junction of small and large intestine. It can be TB meningitis, that is inflammation in the brain. It can cause inflammation in the, it is called as uveitis, one of the layers inside the eye, anything. But TB is 100% treatable and curable.
Okay.
That we have to always remember.
Okay.
It can be severe and non-severe. Why is it killing so many people? Because number one, diagnosis, people are sometimes presenting late to the health facility to get diagnosed. If diagnosed, they are not receiving proper type of therapy. Right drug, right doses, right duration. That is how it has to be in any infectious disease. Drug, dose, duration. Okay. And of course, immunity plays a lot of role.
Okay.
When we took our MBBS education, it was all about poor socioeconomic strata, people staying in slums, overcrowded places, humid places will catch TB and suffer. Poor people. Not the case since last, I can say, 20 years. Affluent people are also suffering because malnutrition is not always undernutrition. It can be overnutrition also. We are seeing a lot of obesity. It can be a risk factor for catching things like TB.
Wow.
They used to say the vices that will kill you. Smoking, alcohol, junk food. Till now, junk food. The fourth one is chair. Sedentary lifestyle. That is adding to our enemies. So, no exercise, poor nutrition. Poor nutrition is, I'm not saying somebody is underfed. In fact, overfed. Ordering all the time from online sources, eating anything at any time. That takes a toll on your immunity. So, anybody can suffer. It is nothing related to rich, poor, affluent, non-affluent anymore.
So how do I ensure that I get the right treatment at the right time? Like at what time is the time for me to go to a doctor, say, let myself get checked for this TB? And what are the kind of tests that you can do to get a confirmed diagnosis of TB?
So as I said, if you have pulmonary TB, means lung TB, you will come with cough, which is not going for say 3 weeks. There could be fever, loss of appetite, hence the loss of...
Is it like a lot of violent cough or just regular cough also?
It can be regular cough. So, this 3 weeks cough is a big threshold. It can be cough variant asthma, as we discussed. It can be infection like TB. It can be cancer, or it can be lung fibrosis. So, we'll talk about those things also. But cough, sometimes bringing out blood in the sputum, fever, loss of appetite. These are classical symptoms of TB.
It's not normal to have 3 weeks of cough, basically. Like,
It is not
you
normal.
get 3 weeks, you have to go.
Go to a specialist.
You can't say it's pollution in the air which is making me
No,
cough.
no. At least do a chest X-ray, meet a pulmonologist,
Hmm.
and get yourself diagnosed with whatever it is.
Okay.
So this is for the lung TB. This presentation.
Hmm.
Now somebody who comes say I am having a swelling in my neck for a month.
Hmm.
Okay, that is one presentation.
Hmm.
Somebody who is having headache, projectile vomiting, TB meningitis.
Hmm.
Somebody is having irregular stool,
Hmm.
again weight loss. There could be intestinal presentation of TB.
Hmm.
A chronic backache. No, my office chair is not good.
Hmm.
A backache more than again 3 weeks. Please show orthopedic doctor. Get a X-ray or a MRI done.
Hmm.
Sometimes vertebral TB. That means TB in the
Bone.
vertebral bones or any bone, muscle, etc.
Hmm.
So a particular a TB in a particular system will have those symptoms. Once you present with those symptoms, the investigation will be accordingly.
Hmm.
So if there is lung TB, I will do a chest X-ray and sputum examination.
Hmm.
Not only to see whether it is TB, to see we do TB culture test
Hmm. Hmm.
to see what kind of TB it is, drug sensitive or drug resistant.
Hmm.
And same is the case. Suppose somebody has vertebral TB, a CT scan guided biopsy is done
Hmm.
to be sent for histopathology
Hmm.
and also TB culture.
Hmm.
Or somebody has had abdominal fluid,
Hmm.
removed it,
Hmm.
send it for cytology and TB culture,
Okay.
apart from other tests. So the system that is suffering will guide you towards the
Right kind of test.
right kind of test to be done.
Hmm.
And if it is drug susceptible TB, 9 months of treatment takes care of it.
Hmm.
If it is a drug resistant TB, then there are certain drugs that are available now and they are available only with the government clinics,
Hmm.
and which is a good thing because they will regulate a certain
Distribution.
treatment. There will not be irregularities in the treatment,
Hmm.
and those drugs are really effective,
Hmm.
and 18 months treatment takes care of that.
Okay.
So that's why I said it's curable and treatable.
Understood. Understood. Okay. So we went from chronic conditions of young to acute infectious diseases. I also want to cover something like self-inflicted damage to yourself, right? Of course, we don't need to go into smoking as a thing because the effects of that is now very well documented, and thanks to a very successful campaign by government, many people know the bad habits that bad habit can cause damage, right? But I do have a question on saying there is now an upcoming discussion, right, that vaping is safe. It has no tar in it. All that black soot that you show in the ad for cigarettes is not there. It's water vapor. It's perfectly fine for lungs.
It's equally bad. And it's dangerous because smoking, whether it is a cigarette or a BD, everybody knows about it now, as you rightly said. A cigarette smoke has 4,000 chemicals, 300 of which are known carcinogens. Means we know for last 60 years that these 300 chemicals can cause cancer of any type in the body. Apart from causing thickness of the blood flowing in your body, which can give rise to heart attacks and stroke, etc. All that is said and done. It has nicotine, which keeps you hooked on to the smoking. So the smartness was, okay, you want nicotine, I will let go these 4,000 chemicals. I'll put this nicotine in that
water vapor.
Which is not a water vapor, which has other substances like formaldehyde. There are multiple other substances which are chemicals.
Okay.
To keep it in that form so that one can
take the
smoke it.
delivery.
Yes. And you have been hooked on to nicotine. Your brain is hooked on to the nicotine. But again, you are taking, if not 4,000, you are taking a dozen of different chemicals inside your system. So it is not water vapor and nicotine. It also has preservative, you can call it, or some kind of this formaldehyde kind of thing. What is formaldehyde? We do surgery from some part of the body and we send that sample in formalin, that is formaldehyde, to the pathologist colleague for the diagnosis. That formalin you are inhaling. It is not safe.
Okay.
At least cigarette, you are smoking a cigarette.
So this is a known scientific fact. It's
absolutely non-scientific. There are no two things about it.
Okay. So then
has to be discouraged at all possible levels.
Okay. Fair. Okay. So now coming to a little bit of middle age situation and also, there is this rising incidence of discussions around this word called COPD.
Right.
Right. What is COPD, right? To whom can it happen, and what are the triggering reasons for a disease like this?
So the full form is chronic obstructive pulmonary disease. Chronic means it is long standing. Obstructive means again those breathing pipes are going in an obstruction. They are becoming narrow. And that's why the airflow is not happening properly.
This is not asthma then.
This is not asthma because I'll tell you why. And also there is destruction of certain part of the rest of the. Sorry. There is also destruction of some part of the lung along with that. In asthma, it is just narrowing of the breathing tubes. Here, there is narrowing of the breathing tube and also some structural destruction of some part of the peripheral lung, which is irreversible. It doesn't get repaired. So, chronic obstructive pulmonary disease. Why it is not asthma? Asthma can catch a 5-year-old child, as we discussed, a 20-year-old girl who have no vices. COPD typically was described in smokers, people who started smoking, as we discussed that 4,000 chemicals and they do damage the lung. But now as we know that it is not only about smoking the cigarette, it is also because of pollution. Why this initiative is I really appreciate our government doing this activity for last 10 years of replacing all the chulhas by gas cylinders. And that pollution, operating a chulha, basically you are putting in things and you are blowing into it to cook your food. Those women were constantly exposed to a smoke, which is not good. All the soot is going inside. Vehicular and industrial pollution we are aware of. We also talked about the indoor air pollution. People who have used a mosquito repellent every night 8 hours for 5-10 years also can present with COPD like lungs. So any kind of seen and unseen fumes can torture your lungs. It is not only cigarette smoking. It is all this. And since it is progressive, it has its own issues. Like in asthma, you treat a patient and as I said, he can play any sport, she can go scuba diving, etc. In COPD, there is always some limitation once it is developed and diagnosed again with a pulmonary function test. Again, the treatment is with inhaled medication. Physiotherapy is very, very important. Also, we discussed about exercising your respiratory muscles. And staying away from these noxious gases and substances is very important.
So I want to come to this last part that you're saying, the environmental factor at play here, right? What are we to, as citizens of this country, right? Like, what are we to do with the fact that the AQIs are going so high? Is this a contributing factor to COPD?
Of course it is, because there is a lot of construction activity going on for infra projects, etc. So there is a lot of dust pollution and it is a mix of everything. So sometimes in Mumbai especially, there are very old buildings which need to be demolished and new buildings are coming up. So when those old buildings are demolished, it is not only the dust of that falling structure. There are lots of fungi and all these substances are getting released in the environment. Then all these debris is carried by certain trucks, although they are covered, they are carried across. Then you are seeing lots of flyovers and road construction happening and a lot of infra work happening. So there is a lot of dust and cement and all so many factors. Metal fumes, where they are constructing bridges, etc. They are putting on those girders. You have to do welding. So there is a lot of metal. So all sort of you can say pollutants are around us. So that is definitely adding to it. But as citizens, as I said, indoor air pollution we have to manage, which is in our hands. Wherever possible, planting a tree, not only in our garden in the balcony, but also outside, somewhere in a park or at a road, with the help of our local municipality or taking their permission and doing it as a drive. And when you are passing through such polluted areas, just wear a N95. I think
that is the best.
That's the best when that is happening. When that,
if people used to, have like this kind of like make fun of these Eastern cultures where they used to always wear masks, but turns out I think they're probably smarter about their lung health, and we would benefit by replicating their behavior right now.
Absolutely. Especially when people need to know in our setup that once I am sick, I should wear a mask. I cannot keep, and another social habit of our country is spitting everywhere, which I do not know how to. I mean, I really, through your channel, I'm again appealing to our governments that please be strict on this. Like you were strict for making people wear masks during COVID, or maintaining 6 feet distance, or hand washing. We were bombarded with all that, and it helped. It does help.
It does help.
Spitting has to. We are the only country probably on the planet Earth where people are just spitting right, left, and center. They are. Somebody has TB and spits on the road. You are exposing. Anyway, he is infectious to 10 people in a year. Anyway. And if he's spitting, all those bugs are open in the air, and anybody can.
Exponentially increasing the risk.
Absolutely.
So, moving on to the next stage of one's life, right? I think in the later stages, actually before that, we can just think about another disease that I've heard about, but I don't know anything about. What is this interstitial lung disease, right? What does it mean, and how does one get it?
Okay. So in layman's term, it is lung fibrosis.
Okay.
Interstitial lung disease is a medical terminology. Lung fibrosis means literally the lungs become hardened. Our lungs are like sponge. A sponge, compresses and opens. With every breath, our lungs are also compressing and expanding. They're behaving like a sponge. But when part of the lung, like an old sponge, sometimes a part of it gets, thickened, useless. There are lots of holes in it. That part of the sponge becomes functionless. Similarly, part of the lung, or sometimes progressively both the lungs, can get thickened. And it becomes useless in the sense that there is no air exchange. What is the work of the lung? Take oxygen, throw out the carbon dioxide, and that taken oxygen has to be given to rest of each and every cell of the body.
Correct.
But when it gets fibrous, that means gets thickened, it cannot do air exchange. It is unable to do that. And that is when there is no oxygenation to the rest of the body. This chronically can also lead to what we call as pulmonary hypertension. The blood pressure of the lung goes up. And it can pose pressure on the right side of the heart. And it can cause right heart failure. So these are all progressively life-threatening conditions. There are 150 different types of ILDs, interstitial lung disease, 150. But they have been classified to make us understand how to go about it, how to diagnose and treat.
But how does this happen?
Yeah, exactly. So in certain people who have connective tissue disorders, some people who have arthritis, various types of arthritis are there, scleroderma and myositis. There are different types of these connective tissue disorder which affect your bone, the joints, the skin, and the microcirculation. They also affect lung. So that is one type.
Okay.
Then there is another type where you have been exposed occupationally, for example. A coal miner, people working in coal, people working in mining industry, where they are exposed to silica and any kind of dust chronically. Or
silica is like, I would say, the same construction kind of dust also is the same?
Yes, crystalline, that whatever exposure. So basically grinding, cutting of,
Stone and
tiles
everything.
and all the stones, correct. So that stone dust going inside, it's an insult again and again to the lung tissue. And that is when the process of fibrosis starts. So occupational exposure. Third most important is what we call as hypersensitivity pneumonitis. It can happen because of exposure to pigeon excreta and pigeon feathers, which is particularly common in certain places in Mumbai. Or there is a habit of feeding pigeons there is large area which is kept for pigeon, and you give grains to the pigeon, and you're standing there for 15-20 minutes also for a number of days or months. That excreta and those inhalation of those antigens which are there in that pigeon excreta and feathers inflames your lung.
So this is like dangerous that like these societies have so many pigeons now in our cities and everything.
It's very dangerous. So that's why corporations have come up with certain strict acts that do not feed pigeons. Definitely not in the public places, because you cannot gather pigeon at one place. It is dangerous for anybody's lungs.
Wow.
So this is hypersensitivity pneumonitis, which is one of the commonest lung fibrosis cases in Mumbai. And then there is something called as idiopathic pulmonary fibrosis, means idiopathic.
Don't know.
Cause is not known. So these are certain types of fibrosis, and then the treatment is giving a course of steroid initially to take care of the symptoms. And then there are certain antifibrotic medication or certain disease modifying agents which kind of try and keep the fibrosis where it is and prevent rest of the lung from suffering from it.
Understood. Another disease that I've heard of for generally for older people, but maybe it happens to youngsters also, is pneumonia.
Oh, it is, yeah.
Is this common, and is it true that it just happens from exposure to cold?
No. So pneumonia means infection of the lung. It can happen with bacterial sources or viral pneumonia or fungal pneumonia, or there are certain tuberculosis. The bugs from tuberculosis family also can give rise to lung infection. So any extremes of the age or at any age person can catch pneumonia. Because
is it like what? Like, so you say that if I have if I have lung infection, right? Upper infection, lower infection. But is it like what? Pneumonia is like a higher order of infection? What is pneumonia?
Yes, because pneumonia is directly, when you say upper, that means your upper respiratory infection you're talking about. Just sore throat and runny nose and cough and fever. Pneumonia means a patient comes with chest pain, sometimes blood in the sputum, very high grade fever, and at times even breathlessness. A younger, say somebody who's 40-50-year-old will present like this. But a 80-year-old man will not present like this. He will be just lying listless in the house, and the family will tell he has been very active, and last 2 days he's just lying in his bed. And that's why we have brought him to the hospital.
Feeling tired
Or not able to move, as if he is in a semi-conscious state. Sodium has gone down if you do the blood test. But if you do the investigation, X-ray is showing pneumonia. This is how elderly will present with pneumonia. So this is classical bacterial pneumonia.
Okay.
And a proper antibiotic cover should take care of it.
Okay.
I mean, yes, the mortality can be 20 to 30%, especially in the elderly. But picked up in time, treated with proper antibiotics, it's...
So basically your immune system has become weaker, so it's not able to fight off the infection and it becomes worse.
Correct.
Right. So there is this thing, a push for like pneumococcal vaccines and all of these things. Do they help?
They do help.
Okay.
We have seen this, that there are two types of pneumococcal vaccine. There is a protein conjugate vaccine, which is to be given first. And then there is a kind of an antibody vaccine. I cannot say in more simpler terms. It's like a booster after 8 weeks from the first one.
Okay.
Once you have taken these 2 doses, previously it was recommended above the age of 60 or 65. But frankly, we now recommend the kind of pollution or kind of exposures that are happening, especially in metro cities. It is best anybody can take this. Pediatricians do have in their vaccine program. And then there is what we call as flu shot, vaccination against influenza, which has to be taken once a year.
By?
Because that will...
No, by who? By elderly after 60?
Literally from 0 to 99. As I said, pediatricians have it in their vaccination program for children.
Even like people who are 20, 30, 40-year-old?
They can take it. Because a lot of traveling is happening, even this younger people for job or whatever, they're traveling a lot. There's a lot of traveling happening. And you are exposed to viruses and bacteria all the time. In an aircraft, 300 people are sitting, 5 people also have some kind of viral infection. It is very easy to catch infection.
Yes.
It's best to take it simply because it has been seen that they will cross protect you against these kind of varieties of COVID also. Influenza vaccine will generally trigger your T cell immunity, which will grossly protect you against other viral infections also.
So heading to the final stages of discussion in this, right? Like coming to lung cancer, what are so outside of smoking, right? Is lung cancer something just genetic, or is it something that there are contributing factors to it that I can have in life which can increase my chances of getting lung cancer?
Again, coming back to the same discussion of pollution, because till say you can say almost 25 to 30 years back, lung cancer was always associated with smoking.
Yes.
And then there are types of lung cancers like small cell lung cancer and non-small cell lung cancer. In non-small cell lung cancer forms the major numbers, and in that squamous cell carcinoma always top the list because it was always associated with smoking, and those who smoked may have it. But now there is something called as adenocarcinoma, which is a type of non-small cell carcinoma which is not associated with smoking. And we are seeing it in especially increasing. So previously it was male smoker. Now it is a 50 or a 60-year-old lady, obviously never smoked or not really exposed to pollution of that sort, is what was thought. But adenocarcinoma is increasing and it is exclusively related to pollution.
Okay.
Now, be it indoor or outdoor, it is difficult to pinpoint. How to avoid it? There is no one single answer to it. Genetic predisposition is always there, of course, for any such kind of illnesses. There could be certain tests which can say that maybe you can be prone for this. But how do you stop it at this point of time from happening? I doubt we know about it still. We do not really know about it. And of course, having a good lifestyle, having, greens, fruit, deep breathing exercise goes a long way. And if there is a cough which is more than 3 weeks, please rush to a doctor. Do at least a X-ray, a CT scan if necessary. At times, it is also on the primary care physician who are seeing the patient before he comes to the specialist. Sometimes is lost in giving symptomatic treatment, or X-ray is done, but okay, there could be something somewhere not really paid attention to, or thought it could be TB and given anti-TB treatment. So if there is some suspicious shadow in the X-ray, always go for a CT scan of the chest. Now everything is available readily, I'm sure, even in C-size cities in our country, and there are very good diagnostic centers, including imaging centers, including excellent doctors who are running those, seeing those images and reporting. So that dearth of non-availability of facilities or this thing is very less now. So
that is the approach to it.
Yeah, one has to be aggressive about diagnosing it.
And you want to catch it much earlier.
Earlier, because if it's a limited cancer that you pick up in the in as far as lung is concerned, and if you can surgically remove it, one can really survive more than 10-15 years also. But what happens, unfortunately, in the presentation can be little late from the patient side, or sometimes from the primary care physician, referral to a specialist happens little late, and we end up finding lung cancer patients in stage 3 or stage 4, which is not a curable condition. We treat them, but with palliation just to make them comfortable, etc. But this, if early pickup can happen, cure can be also offered surgically.
So tell me, I mean, here the diagnostics could have, it sounds, feels like a double-edged sword, right? We all know that X-rays has radiation exposure to you, right? So is it possible to get these kind of, so one is, of course, when your doctor prescribes you have had cough for 3 weeks, doctor wants to know, and obviously that's when you must do an X-ray, because he tells you to do an X-ray or do a CT, because that is a requirement at the time, right? But there is an upcoming trend of like saying that, I want to do preventive health checkups, right? How relevant is it to do, let's say, I should do an X-ray every year? Or now there's an increasing trend of saying that, I want to check my calcification score of my arteries. So I want to do a CT scan every year, right? This kind of radiation exposure, do you think is potentially dangerous for patients, or could potentially lead to cancer diagnosis eventually if you're doing this too frequently?
I think once a year is a safe bet. Doing a chest X-ray or a CT scan if necessary. So this calcium score CT scan, if there is a family history or if there are risk factors like somebody has been a smoker or a known this thing
High
like high
lipid profile.
cholesterol, yes, exactly, or really sedentary lifestyle, then once in a year or once in 2 years after you have turned 40, makes sense. Once in 2 years should be good. But in a standard preventive health checkup where you are doing you are doing blood test and cardiogram, doing one X-ray a year is not a problem.
Not a problem.
In lung cancer screening specifically, there is something called as low dose CT scan.
Okay.
As against whatever dose of radiation is used in a routine CT scan. Suppose I have a patient who had been a smoker, stopped smoking. Suppose he's say 45-year-old. And in routine health checkup, there was small shadow seen in the X-ray. A scan done. It just showed it is like a 6 to 8 millimeter nodule. That doesn't make any sense because it is, you don't have to go after that. It's a very small one. But he has been a smoker. Now I want to screen him, for example. Then every 6 months, I can do a low dose CT scan, which is like 1/3 of the radiation that you are giving. And if that nodule is growing in size, then I can go after that lesion to do a biopsy or maybe do some kind of diagnostic testing for it. And then maybe go ahead with the surgery. And that is how many times early cases can be picked up as far as lung cancer is concerned. And that goes a long way.
So you would say it's recommended that you should get yourself like at least once in 2 years, get after a certain age, get yourself a scan
the
done.
X-ray, scan only if clinically relevant. If there is so there are, algorithms for that, for clinicians. Whom do I ask for a low dose CT scan once in 6 months or once in a year? There is an algorithm for that. Somebody who has had family history of lung cancer, somebody had been a smoker, or somebody who's above 60 and was a smoker or is an active smoker. This is one indication. And if I have seen some lesion in the X-ray in the past, but at least one X-ray for such a patient every year is not a bad idea at all.
Okay, perfect, understood. I have a bunch of questions which are like trending questions on social media, or some of the chatter around these discussions are there. It would be good to get an they're linked to lung health,
Sure,
so to speak, right? So it would be good to get your opinion as an expert on these, right? So I'll just shoot them one by one, and then you can give your opinion, a quick one. Is chest pain related to lungs? Because while chest pain is a symptom of heart attack, gastritis is also there for this, right? So how do I know that, like, when I'm getting pain in my chest or I'm having discomfort in chest, is it a pulmonologist I should go to? Is it a cardiologist I need to go to, or a gastroenterologist I need to go to? Like, where do I go?
right. So if it's a 20-year-old boy complaining of chest pain, generally it could be indigestion. And maybe a gastroenterologist or your family doctor can give you antacid and you are taken care of. But if a 40-year-old man is complaining, then go do a cardiogram and maybe show a cardiologist. Chest pain is not a common symptom of lung problems.
Okay.
Chest pain comes only in 3 specific conditions as far as lungs are concerned. There is something called as pleuritic chest pain. As we discussed about pneumonia, when there is infection in the lung, so there is lung and there is covering of the lung. When there is infection in the lung, this covering gets irritated. That is one pain. Then if there is a tumor or a lung cancer, which is again troubling that, then one gets it. And the third, rare this thing is, but it is there, what is called as pulmonary thromboembolism. When there are blood clots in the lower limb circulation, which can lodge in the lung circulation and cause pulmonary infarct, like you have a heart attack. This can be called as a lung attack. So, but these are really rare conditions where these conditions aren't rare, but to get a chest pain as a pulmonology symptom is a lesser common thing. But cardiology,
or maybe I feel like when there are so many branches of sciences, it might be best just to go to an internal medicine MD in a hospital, and maybe he can direct you to the right specialist.
Doing a simple chest X-ray and an ECG will really help you triaging where you want to go. You just go to a ER of a hospital, X-ray, ECG, and depending on that,
They will guide you
taken forward.
which department to go.
Correct.
Right. Okay. Another question that is asked frequently is, can mouth breathing harm your lungs over time?
In fact, if you have a lung issue or a respiratory issue, you will be doing mouth breathing.
It's reverse. It's actually a symptom of that.
Right. So, especially in children, if there are enlarged tonsil or enlarged adenoids, there is a gland called as adenoids, which is like a tonsil, which is, you cannot see it with eyes. Tonsils, you can see it with your, on clinical examination. When that is there, your air passage is narrow or your nose is really choked with cold, then you will be doing mouth breathing. So, if you have an upper respiratory condition, you are doing mouth breathing.
So a lot of people just at night you will see that they're sleeping, they're breathing through their mouth. What is that? That is some symptom or something?
That is obstructive sleep apnea. That could be indicative of obstructive sleep apnea.
Okay.
Apnea means stopping of the breath. Sleep apnea means stopping of the breath in sleep. And obstructive means your air passage during the sleep gets narrow. Everybody's. When we are inhaling, it becomes narrow. When you are exhaling, it opens. But in certain people, it closes so much that the airflow gets obstructed. And that's when that's why their mouths are open, trying to, it's like a air hunger. They do not realize because they are fast asleep. But the bed partner will know what is going on. Sometimes there is stopping of the breath. And that person literally subconsciously in the sleep wakes up, or the partner wakes that person up. And again the breathing starts.
Wow.
So that can be early symptom of obstructive sleep apnea.
Okay. Are nebulizers better than inhalers?
Nebulizers are to be used in a ICU setup when a critical patient has come in, or somebody who is mentally obtunded or an unconscious patient, but who has a lung condition and inhale medication has to reach the lung. That is
I've seen children also being given nebulizer.
Which I do not approve of that practice.
Oh, okay.
Nebulizers are meant for very specific condition, and somebody who has a COPD going home from the hospital after discharge for some time can use nebulizer. But even in children or these kind of COPDs, there are certain spacers with a mask. So there is a mask, there is a spacer, and then there is that typical inhaler. A combination of those inhalers given through this kind of setup work as better or maybe as good as or maybe better than nebulizer. So I personally prefer giving this kind of inhale medication than nebulizer. It has become a fashion or a practice for some reason to just prescribe a nebulizer, which is like 2,500-3,000 rupees machine just sitting at home to be used.
These are two different drug delivery mechanisms for similar kind of drugs.
Correct. So medicines are same, but these are different drug delivery systems. And giving inhalers through a spacer or a mask, even in elderly, not only in children, even in elderly, it really works wonders.
Okay.
It depends on the kind of medication that you're using.
Okay, fair enough. Okay, another thing is that salt therapy has been around for decades, but does breathing salty air actually help asthma or COPD? People say, samudra ki hawa is good for your lungs and everything like that.
Nothing of that sort. There are people who have asthma and they suffer from it while in Mumbai, and they go out for a trip in, say, Goa, Kerala, they are fine. But there are enough people in Kerala who are suffering from asthma and feel better when they come to Mumbai. So salt air or inhaling normal saline is, in fact, it can cause more bronchospasm. When you are inhaling, there is a thought process to give normal saline inhalation to bring out phlegm. But that itself can cause bronchospasm. It's an irritant to the mucosa, the inside lining of the breathing pipes.
Okay. So there is no symptomatic relief to be found in breathing salty air or something like that.
No.
Okay. So another one then, if not salty air, people say, and it has been an age-old practice, at least in my household, right, is inhalation of steam. Right? Is inhalation of steam helpful in any way, either with regards to relieving symptoms or improving lung health?
Not for lung health. It is helpful when your nose and sinuses are choked.
Okay.
So, if you inhale steam, that is basically helping your mucus to become little loose so that you can blow it out, or it can get drained out.
But doesn't help with
Per se,
asthma or
for the lung,
COPD.
it has no, it has no role.
Not even for asthma,
No,
nothing.
no, no.
Like the warmness helping with release or something, nothing like that. It's not a natural bronchodilator, is it?
It is not. Unfortunately, no.
Okay. Um, um, we discussed asthma at night, so I think I'll skip that one. Is there an element of any connection with saying foods worsening respiratory health, or let's say asthma essentially in people?
It does. There are certain foods which have very strong coloring or flavoring agents in it, act as a irritant to the respiratory health.
Oh,
Like we talked about mosquito repellents or incense stick burning, that is a direct insult to the respiratory health. But these kind of strong coloring flavoring agents, especially the Ajinomoto, which was used I don't think anybody uses it anymore, but to flavor your Chinese food, that was a very strong thing
wow.
for the lung health. And also aerated drinks, they can trigger asthma symptoms.
Okay, great. This is all we have. Thank you so much for being so patient with our questions and explaining every step of life, how we can take care of our lung health and be careful about it. I think for me, one of the key takeaways, and I think fundamentally, is that there is a point cutoff of symptoms. I think around 2 weeks plus, right? 2 to 3 weeks, where if you find yourself suffering, please don't ignore it.
Correct.
Right. I think we are now living in a world where a certain amount of irritation and, like you say, insult to our lungs is a given.
It's a given, yeah.
Right.
Fortunately.
So I think all we need to do is be careful about like when we find it acting up and our bodies is telling us that
Correct.
it's been 2 weeks, we should seek help. And a lot of these things, like you pointed out, are actually treatable.
Treatable, yeah.
And they can be managed.
Correct.
Right. And I think the other thing which has been really insightful for me is this entire discussion around asthma. I spent a lot of time on it, but I think it's really valuable to know that it's a manageable condition. And for me, one major dispelling of myth was that people actively work towards saying, "Oh, I want to get off medicines," but actually, that example of the specs for us you gave me a very good perspective to look at it. Right. And I think that will be very helpful for people to realize that you could live a fuller life.
Correct.
If you just took the medication for it as you would do in diabetes or something.
Absolutely right.
Right. Okay, so doctor, one more question is there in my mind, and I find this to be a pattern that I'm detecting. Right. Seems like respiratory illnesses become more common during monsoon season. Right.
Right.
So why does that happen? Why is that during this season respiratory illness increases?
I guess it's because of the increased humidity, moisture, and especially people who have a baseline condition like allergic rhinitis or asthma, they become more prone to develop respiratory symptoms, worsening of their existing condition or catching the infection. Also, people who are elderly, it is because of this moist condition around you. There is at times 7-8 days there is no sunlight. Sunlight is a very good disinfectant. You know it. If that doesn't happen, then you are exposed to molds, bacteria, viruses, and your respiratory system becomes very prone for getting infection also, especially in elderly or people who are immunocompromised in some way, like uncontrolled diabetes, or people who are on cancer chemotherapy, or we have a lot of organ transplant patients around us now, kidney transplant, liver transplant patients who are on immunosuppressing agent.
And I guess the answer would be to, much like in these seasons, susceptible people should cover themselves in masks.
More than that, if there are symptoms in that, of course, if it is cold, cough, fever, within 48 to 72 hours, you please report to even a family physician and get yourself treated so that it doesn't get prolonged. Or if your asthma and rhinitis symptoms are worsening, then step up your treatment with the help of your pulmonologist. That's the best way to do it.
Thank you so much, Dr. Samir. Really a pleasure to talk to you.
My pleasure, sir. Thank you for having me on your show again.
Thanks a lot. Thanks.
Thank you.
If you like the podcast, please hit the subscribe button or share it with someone whom you think will need it.